that takes us to, you know, the question of consolidation and maintenance. And, you know, we just have a few minutes here, but Peter, what's your approach to maintenance today? You know, what drugs for how long, and low versus high risk? Where are you at with that?
So I think for the majority of patients, lenalidomide is the standard of care. You know, it has a role both in standard risk patients as well as high risk patients. I think the MRC-11 trial showed us that lenalidomide maintenance actually is active in patients who have the 414 translocation as well as deletion 17p. So lenalidomide, and until disease progression for now, until a study tells us otherwise, because the CLGB and MRC-11 trials showed a survival advantage post-transplant with the use of lenalidomide maintenance therapy until disease progression. I think as far as single agent proteasome inhibitor maintenance, there's really no good randomized data supporting that, you know, for patients with deletion 17p or the 414 translocation. I have gravitated just based on the experience from the Emory group, and now we've got my colleague Saad Usmani's S1211 trial looking at RVD induction therapy followed by prolonged len-bortezomib maintenance therapy in high-risk patients with a very respectable median progression-free survival that came out of that study. I have gravitated towards lenalidomide bortezomib combination maintenance for patients with high-risk disease.
Just for high risk, or not for your low risk patients?
Not for the standard risk.
All right, we're going to have to be a bit rapid fire here. So Natalie, what's your approach right now? We accept lenalidomide for everybody. Are you adding?
I'd go with Pete. Len for standard risk, VRD for high risk.
Including dexamethasone?
Usually we cut it out very quickly. It modulates some side effects, sometimes some of the cytopenias, but you know, at least it usually some starting dose of dexamethasone, but not 40.
And Nupur, I know you're big fans of lenalidomide in Boston. Are you using bortezomib as well? And
bortezomib in the high-risk patients. High-risk patients add bortezomib, change to ixazomib if they have neuropathy.
Well, of course they will by then, but I'm just joking. Nupur, how long for? There was always this debate that Paul loves to treat forever, and most of us are like, no, 2 or 3 years is probably enough torture.
No, I continue till forever unless they have toxicity, which precludes them from being on it.
All right, Tom, the last word for you, and maybe you could talk to the role, since you're doing MRD testing, do you use any consolidation if it's still positive?
So we don't use any consolidation, but for the high-risk patients, I think I'm a little different. So if it's a high-risk patient, for me, that is MRD positive at 3 months based on our test, I'm going KR plus or minus D as the maintenance strategy vis-a-vis the MRC study, the MMRC study. And so K is my preferred maintenance strategy for the high risk. And then for standard risk, I am just with lenalidomide.
So I guess I'll just tell you what we were doing before I left Mayo, which was, I guess personally, a little bit more aggressive. I was using lenalidomide and bortezomib in almost everybody, but actually more and more turning to daratumumab if they were MRD positive, which I found many of my patients were still MRD positive at post-transplant. And I sort of got the notion that daratumumab, even though it's not really approved yet in this setting, as a consolidation to try and get to MRD negativity was worth a shot. So that's kind of where I was leading. I mean, outside of the US, of course, many of these things are not feasible at all. And lenalidomide, of course, will be the standard of care, as you've all said, for everybody, time limited or forever. And then the use of bortezomib perhaps in the higher risk patients. Of course, in Europe, a second transplant is also quite commonly employed. So the last question in this section is anybody doing second auto transplants for their high risk patients? Natalie, I'll pick on you because you're kind of the transplant avid person here.
We actually haven't, just because I think we were pretty swayed initially by the 0702, at least the early data that really didn't show a benefit for tandem or consolidation. They updated their data at ASCO, which was very interesting, looking at not just intention to treat, but who actually received the tandem, and they were able to show a benefit for tandem, particularly for high-risk patients. You know, speaking again to the MRD issue, they also showed that there was, once again, a significant benefit for long-term lenalidomide in terms of maintaining MRD negativity. And I thought that was very interesting data.
Anybody doing second transplants?
We're not at this point. And I think that that second look at the stamina trial was a bit of cherry picking, to be honest with you. I mean, they're taking the patients who went through the 2 transplants, which are probably the fittest patients, you know, so in the absence of randomization of that specific subgroup of patients, you really can't say anything one way or the other. So I've gravitated away from the 2 transplants.
And I think one thing which we should highlight here, you know, we keep talking about a second transplant benefiting the high-risk patient population. Remember, including in the Forte trial, including in the Stamina trial, the maintenance did not include a proteasome inhibitor. It was lenalidomide alone. And that's why I think, you know, it's hard to put it into practice because that's not what we typically do for our high-risk patients.